Welcome back to the deep dive. Some of the most fascinating protocols we cover are those where really high-stakes decisions hinge on low-tech, purely observational skills.
That's right.
Today, we are cracking open one of those crucial clinical guides, the structured step-by-step examination used to assess peripheral vascular disease, or PVD, and its catastrophic culmination, gangrene.
And this is really a deep dive into vascular triage. PVD, at its core, is arterial insufficiency. It's a chronic, progressive failure of the circulatory system to deliver enough oxygenated blood.
So we're really looking at a progression.
A clear progression. What we're looking at is the road from simple claudication, which is, pain on exertion, all the way to ischemic rest pain, non-healing ulcers, and then ultimately tissue death. It's a roadmap of arterial failure.
Okay, let's unpack this. Our mission here is to really understand this structured clinical protocol that the experts use. We're aiming to see how they quickly and accurately identify the exact location of the arterial obstruction.
And quantify the severity.
Exactly. Quantify the severity of the ischemia and determine limb viability. We're translating the body's subtle, almost desperate signals into actionable data.
And that speed, that accuracy, it's everything here. The physical examination is the non-negotiable first step that dictates the entire treatment pathway.
So it determines everything that comes after.
It determines whether the patient needs immediate limb-saving revascularization, restoring blood flow, or if the condition is stable enough for slower, more conservative management. It is a critical exercise in integrating observation, palpation, and precise timing.
I think the biggest misconception about PVD is that it's just a localized leg problem, but our sources make it really clear that the general examination is just as important as inspecting the foot itself.
Oh, absolutely.
So let's start there.
If you find significant peripheral vascular disease in the legs, you must assume it exists everywhere else. The entire foundation of this assessment rests on the understanding that PVD is usually a localized manifestation of generalized atherosclerosis.
The hardening of the arteries.
The hardening and narrowing of arteries across the entire body. It's a systemic disease, and the legs are often just the most visible victims.
So if a patient comes in with an acutely painful cold leg, what are the immediate general signs the clinician is looking for, the ones that signal an acute crisis, the body's sort of alarm response?
Well, when the arterial supply shuts down suddenly, say an embolus gets lodged in a major artery, it triggers the body's immediate panic response. This is acute ischemia.
Right.
We look for the classic presentation, often summarized by the 5 Ps, though some protocols use 4. It's pain, pallor, which is extreme paleness, pulselessness, paresthesia.
Numbness or tingling.
Right, and finally paralysis or loss of movement.
Those 5 Ps paint a very grim picture. But let's focus on the general signs, the ones we see across the entire body, not just in the limb. You mentioned pallor, sweating, tachycardia.
Exactly. Pallor indicates massive vasoconstriction, a lack of blood flow to the skin everywhere. Sweating and tachycardia, a rapid heart rate. That's the sympathetic nervous system going into overdrive. It's a sign the body is trying to compensate for systemic shock.
So if you see those signs, the clock is ticking.
The clock is ticking very loudly, and the examination shifts from a chronic assessment to really acute intervention planning.
Since atherosclerosis is generalized, you said we need to actively search for atherosclerotic stigmata, signs of arterial disease elsewhere. Where's the clinician focus beyond the legs?
We shift our focus immediately to the heart and the neck. This requires a dedicated cardiac examination. We're listening for murmurs, which could signal valvular disease that, predisposes to clot formation.
Okay.
But crucially, we are listening for arrhythmias, especially atrial fibrillation. An irregular heartbeat, or AFib, is just notorious for allowing blood to pool and clot in the heart's chambers.
And those clots can break off.
They break off, becoming the emboli that then travel down and cause that acute sudden occlusion in the leg arteries.
So that's the critical link you're drawing. The lost pulse in the foot might have actually originated as a rhythm problem in the heart. If you find PVD, you have to assume coronary artery disease is also present.
Precisely. We're connecting the dots. We also listen over the carotid arteries in the neck for bruits, which suggests stenosis there, potentially signaling a risk of stroke. It just reinforces that we cannot treat the leg in isolation. We're treating a cardiovascular patient who happens to have leg symptoms.
Okay, moving from the internal plumbing to the external clues, the protocol highlights the importance of observing lifestyle markers. These are the sort of telltale signs that screen chronic risk factors.
Absolutely. The examination includes reading the patient's environment, so to speak. We have to look for signs of diabetes neuropathy, which is a major, major underlying cause of PVD.
How does diabetes play into this?
Diabetes damages both the small vessels, the microangiopathy, and the nerves, the neuropathy. So we look for evidence of past amputations, specific foot deformities, or that characteristic rocker bottom foot that indicates long-standing nerve damage.
And these patients are more vulnerable because they can't feel the pain.
Exactly. They lose that protective pain sensation.
And then there's that classic visual cue, the smoking fingers. It sounds almost judgmental, but clinically, it's a huge piece of data, isn't it?
It is entirely clinical. Identifying nicotine staining and, the generalized skin changes associated with heavy smoking, it instantly confirms the presence of the single most destructive risk factor for arterial disease.
It just accelerates everything.
Massively. Tobacco compounds accelerate atherosclerosis and cause intense chronic vasoconstriction. It just speeds up the whole disease progression. If you see those signs, you know the severity is amplified.
Before we move on to the leg itself, there are some initial baseline measurements. One is simple, but vital. Comparing blood pressure between both arms. Why is that comparison so critical for a leg assessment?
It's all about establishing an accurate systemic baseline. If the blood pressure in one arm is significantly different, and a disparity of more than 15-20 millimillar Hg is a huge red flag, it suggests an obstruction higher up.
And the arm artery itself.
Perhaps in the subclavian artery, which feeds the arm. If that's the case, the higher of the two arm pressures must be used as the systemic baseline. If you use the lower compromised pressure, you will inaccurately calculate the ankle brachial index later.
And you could underestimate the severity.
You could completely underestimate the severity of the leg disease.
So it's a checkpoint to make sure our subsequent calculations are even reliable. And what about that simple capillary refill check in the fingers?
It gives you a quick snapshot of the microcirculation status systemically. If refill is already sluggish in the fingers, you know the problem is pervasive. A delay indicates that the central pressure is failing to push blood through the smallest vessels effectively. This really sets the stage for the specific assessments we're about to do on the lower limbs.
That really wraps up the systemic context. We've established that this is a whole body disease. The visual cues we're about to look at on the legs are just the clearest sign of this wider failure. Now, we descend to the local examination, which relies on a keen eye for subtle color shifts.
Right. Inspection is really the art of PVD diagnosis. It requires the clinician to move slowly, comparing the limbs in multiple positions. The principle of bilateral comparison is, well, it's non-negotiable.
You can't see the problem without a baseline.
You cannot interpret subtle color, hair, or temperature changes without immediately referencing them against the healthy or less affected limb.
Okay, so let's decode the colors of distress. The skin color is essentially a direct, immediate readout of arterial inflow. We start with pallor.
Pallor is the most basic sign of poor arterial inflow. It's the simple lack of blood. The limb appears startlingly white, particularly in the distal parts, the toes and foot.
But that's not the most worrying color.
No. The truly worrying color is that dusky purple-blue hue. This signifies severe ischemia. It means the tissue is struggling with two problems at once. Not enough fresh oxygenated blood is arriving.
And the old blood isn't leaving.
Compounding the issue, yes. The deoxygenated blood is stagnant and pooling because the circulation is too sluggish to carry it away. That purple color indicates profound oxygen deprivation.
And here's where it gets really fascinating. The use of gravity as a diagnostic tool. The paradox of elevation and dependence. We were basically asking gravity to reveal the circulatory inadequacy.
We're leveraging physics to expose the pump failure. In a healthy person, the arterial system easily overcomes gravity. But in severe PVD, the pump, the heart, and the proximal arteries is compromised. If you elevate the patient's foot, even just a little, gravity causes what little blood supply there is to drain out instantly.
And that's elevation pallor.
Yes. The limb turns dramatically white because the diseased arteries simply cannot fight the gravitational pull to keep the limb perfused.
And then when you lower that same limb, you see the exact opposite effect. Pendant rubor, a deep, dusky red or even purple flush. This looks like a rush of blood, but you're saying it signals advanced ischemia. What's the mechanism behind that alarming red color?
Dependent rubor is a sign of desperation by the body's peripheral vessels. Because the tissues have been chronically starved of oxygen, of ischemia, the local arterioles have permanently dilated. They're maximized, wide open, trying desperately to suck in whatever blood pressure is available.
It's called reactive hyperpesemia.
It is. It's a physiological failure. So when the limb is lowered, The gravity assist slightly increases the hydrostatic pressure, and blood rushes into those permanently dilated capillary beds. Because the vessels are damaged and the blood is moving slowly, it rapidly deoxygenates, leading to that characteristic dusky, often painful, purple-red flush.
So the stark contrast, white when the leg is up, purple-red when it's down, that's the clearest visual indicator of chronic advanced circulatory failure.
It is the clinical hallmark. If you witness that combination, you have confirmed the disease severity is high. It often corresponds directly to rest pain or tissue loss.
Moving on, chronic ischemia leaves, well, physical, long-term scars on the tissue. What specific skin and nail changes tell the clinician that poor circulation has been starving these tissues for years?
The metabolic rate of chronically ischemic tissue is dramatically reduced, so the skin often becomes shiny, thin, and taut, losing its elasticity.
And hair follicles, they need a lot of energy.
They're metabolically demanding, so a very common, easily missed sign is hair loss on the dorsum, the top of the foot and toes. If a patient is naturally hairy but has smooth, hairless shins and feet, that is a huge clue that the blood supply has been inadequate for a long, long time.
And the nails change too.
Yes, the nails become brittle, thickened, and they often display distinctive transverse ridges, similar to the lines that form in response to any major systemic stress.
What about the structure of the foot itself?
A crucial structural change is the loss of subcutaneous fat. Fat is energy storage, and in severe chronic ischemia, the body essentially sacrifices this layer. The loss of that cushioning makes the foot gaunt and much more susceptible to pressure injury, which immediately elevates the risk of ulcer formation.
And where do those initial minor ulcerations typically break out?
They happen where tissues are subjected to high pressure and already have naturally low circulation. This typically means the pressure points. The tips of the toes, especially the great toe, the heel, and the malleoli, the bony prominences on either side of the ankle.
What do they look like?
Arterial ulcers are often described as punched out in appearance, with very pale bases, which reflects the lack of blood supply necessary for healing.
This leads us to the final and most consequential part of the inspection, assessing gangrene. The distinction between dry and wet gangrene is crucial because it entirely changes the intervention timeline.
This is the moment where the diagnosis becomes immediately life or limb. Dry gangrene is the result of slow, purely ischemic death starvation without a massive bacterial infection. Visually, it's black, shriveled, and often described as mummified.
And the key feature that defines dry gangrene.
The clear, well-defined line of demarcation. The body's defense mechanisms have succeeded in walling off the dead, non-viable tissue from the living tissue. So while the tissue is lost, the situation is usually stable and sterile. It often allows for a delayed or planned amputation just above that line.
In stark contrast, wet gangrene sounds like a runaway train.
It is a critical emergency. Wet gangrene means ischemia plus an aggressive bacterial infection. The tissue is edematous swollen and often produces copious discharge and a foul, pungent smell because bacteria are rapidly multiplying in the dying tissue.
And the line of demarcation.
Critically, the line of demarcation is indistinct. The infection is spreading quickly through the planes of viable tissue, posing an immediate systemic risk of sepsis.
And the most urgent physical sign that confirms a rapidly spreading, life-threatening infection is crepitus.
Crepitus is a sign you never, ever want to find. It's a crackling or popping sensation you feel when you lightly press the skin, sort of like walking on dry snow.
What's causing that?
This is caused by gas trapped within the tissues, typically produced by gas-forming anaerobic bacteria, notably Clostridium species. If you palpate crepitus, it signifies gas gangrene, an extremely invasive, rapid infection that requires immediate debridement and often emergent, high-level amputation to save the patient's life.
Wow. That transition from just looking at color to locating crepitus really defines the severity scale. We've covered the visual map. Now we transition into the tactile map, the hands-on assessment, where we start quantifying the failure.
This is really the procedural heart of the protocol. Palpation allows us to confirm the level of obstruction that was suggested by the temperature changes and the visual clues. We're turning subjective observation into objective, measurable data points.
Okay, let's start with that temperature map. How does feeling for temperature help locate the precise level of the arterial block?
As we mentioned, blood is the heat delivery system. The clinician uses the back of their hand to feel the skin temperature, starting from the upper thigh and moving distally towards the toes. They are searching for a sharp, noticeable fall in temperature.
And that drop-off point is key.
The point on the limb where the temperature drops rapidly is a very reliable initial indicator of the major arterial obstruction that's immediately above it.
So warm groin, cold knee block is in the femoral artery.
Exactly.
Warm knee, cold ankle block is in the popliteal artery.
Exactly. It's a quick, non-invasive anatomical clue. Following this, we refine our microcirculation assessment with the capillary refill test, and we need to be really meticulous here.
So we press the nail tip until it blanches white, then release and time the return of color. What is the technical standard for a normal refill time?
The normal standard is a very rapid return of color, less than 2 seconds. If it takes 3, 4, or 5 seconds, it confirms ischemia. The pressure supplying the capillary network is just too low, or the overall volume is simply insufficient to rush back quickly. It's an indicator of profound circulatory impairment at the smallest vessel level.
Okay, then we circle back to the venous refilling test, which remained a bit counterintuitive for me. Why is measuring how quickly the veins fill so informative about the arteries?
Because it connects the whole system. Veins can only drain the blood that the arteries deliver. So if the inflow is severely restricted, the outflow and the subsequent refill will also be restricted.
So how is it done?
The procedure is, you elevate the limb to empty the veins completely, they gutter or collapse, and then you lower the limb immediately.
And the timing standard for venous refill?
Normal refill time should be less than 5 seconds. A delayed refill time, say 10 or 15 seconds, is a powerful confirmation of significant arterial insufficiency because the system just cannot resupply the de-emptied veins fast enough. It gives us a crucial secondary metric to support the delayed capillary refill.
Right. This is the detective work pulse mapping. We are comparing volume and character bilaterally at 4 key anatomical checkpoints. Let's review those locations and maybe discuss the challenges of finding them.
The goal here is precision. We start proximal and move distal. The 4 key locations are the femoral, high in the groin, which is often easy to find unless the patient is obese, then the popliteal, the posterior tibial or PT, and the dorsalis pedis, the DP.
Let's focus on the popliteal pulse, which, as I understand it, is often the bane of every young clinician's existence.
Yeah.
Why is it so tricky, and what's the optimal position for finding it?
It's difficult because the artery runs very deep behind the knee, protected by muscle and adipose tissue, and it requires significant pressure to feel. Often, the best position is for the patient to be lying prone on their stomach with the knee slightly flexed.
Okay.
The examiner places both thumbs on the patella and uses their fingers to press deeply into the popliteal fossa. If the patient is on their back, supine, the knee must be flexed and relaxed, allowing the examiner to press down with both hands to stabilize the vessel. Because it's so difficult, an absent popliteal pulse must always be sought very carefully before confirming it's non-patent.
Okay, moving down to the foot, the dorsalis pedis, or DP pulse. This is the most distal and crucial pulse for determining flow to the toes. Where exactly should we focus our search?
The DP pulse runs right along the top of the foot. You locate the tendon for the extensor hallucis longus, or EHL, that's the tendon that lifts the big toe. You palpate just lateral to that tendon, right where the artery crosses the tarsal bones.
And there's a specific instruction to not go too far.
Yes, the protocol is very clear. Avoid searching beyond the proximal end of the first web space, because if you press too far distally, you might pick up flow from small tarsal arteries or mistake capillary activity for a true pulse. Finding the DP confirms supply to the foot. Losing it is a major indicator of critical limb ischemia.
So once we've mapped the pulses present, diminished, or absent, how do we interpret the character of the pulse beyond just its presence?
The primary rule is simple. Pulses are absent below the point of occlusion, but the character adds a lot of nuance. For example, if the pulse is expansile, meaning it feels like a large, gentle ballooning with each beat, that suggests an aneurysm, a dilation and weakening of the arterial wall.
And what if the artery is acutely tender to the touch?
A tender artery often signals acute thrombosis, a clot forming right there at that location. The sudden inflammatory process surrounding the clot makes the vessel exquisitely sensitive. This is very different from a patient who is simply experiencing chronic rest pain.
And lastly, what about a soft, non-pulsatile artery in a patient with acute symptoms?
That finding, particularly when it's combined with the acute 5Ps, strongly suggests an embolus, a traveling clot that originated elsewhere, like the heart, and lodged higher up, cutting off flow suddenly, but without that local inflammatory response you'd see with an acute thrombosis.
Right. Now we get to the maneuvers that are designed to really quantify this insufficiency. Let's dedicate some serious time to Berger's postural test, Why is this considered the best bedside test for quantifying the severity of chronic arterial failure?
Berger's test is just an elegant, non-invasive method of measuring the functional efficiency of the arterial pump against gravity. It's essential because it objectively translates those visual signs of pallor and rubor into a quantifiable angle, the Berger's angle.
So it moves it from subjective feeling to a hard number.
Exactly.
Can you walk us through the exact procedure and what we're timing and measuring?
Sure. The patient lies flat. First, the leg is elevated 60 to 90 degrees and held there for several minutes. We're timing how quickly pallor sets in and how completely the veins collapse or gutter. In severe ischemia, pallor appears in seconds, not minutes.
Okay, and then the most important part.
Next, and most importantly, the clinician slowly lowers the limb, noting the exact angle at which the foot starts to lose its blood supply and blanch.
Wait, I thought the angle was measured on elevation.
That's a common point of confusion. The Berger's angle is defined as the angle of elevation required to induce maximal pallor, or the angle at which the foot becomes white. The goal is to see how far the arterial pressure can push that column of blood against gravity before the foot empties.
So it's about the relationship between elevation and color change.
It is.
And the crucial threshold we have to remember is 20 degrees. What does a Berger's angle of less than 20 degrees signify?
It signifies severe ischemia. Think of it this way. If you only have to lift the leg a tiny bit less than 20 degrees from the horizontal for the foot to turn white, the underlying arterial pressure is so weak and the compensatory mechanisms are so maxed out that gravity immediately defeats the inflow.
And a healthy limb.
A healthy limb can withstand 90 degrees of elevation without any significant color change. An angle this low is a massive red flag for critical limb ischemia and often correlates directly with rest pain and impending tissue loss.
That is powerful, a number derived purely from observation and gravity. And this test is then further quantified using the capillary filling time post-elevation, correct?
Exactly. After the limb has been elevated and then lowered into the dependent position, we time how long it takes for that dusky rubor to appear. If the capillary refill time, not the simple nail bed check, but the full flush of the foot takes greater than 30 seconds, it confirms profound chronic circulatory failure. We are quantifying the sluggishness of the blood flow in the most extreme way.
Let's move to another functional test, Fietzig's test, or the cross-leg test. This assesses the popliteal artery under stress.
Fietzig's test is a neat functional check. The patient is sitting, and one leg is crossed over the other, resting the ankle just above the knee. This posture creates a mild extrinsic compression on the popliteal artery of the upper leg.
Okay, and what should we see?
In a healthy individual, the hanging foot will exhibit slight rhythmic oscillations synchronous with the heartbeat and the popliteal pulse.
But if PVD is present, those oscillations disappear.
Right. Absent oscillation indicates PVD. The mild compression is enough to shut down the already compromised arterial flow past the knee, proving the circulation is highly tenuous.
Our sources also briefly mention tests for thoracic outlet syndrome's Adson's test, the elevated arms test. Why include these upper body tests in a PVD protocol?
It's all about differential diagnosis. We're trained to think of PVD as atherosclerosis in the legs, but sometimes arterial insufficiency can mimic PVD due to external compression, particularly in the upper body.
I see.
Thoracic outlet syndrome occurs when blood vessels or nerves are compressed between the collarbone and the first rib. These maneuvers, like Adson's, where the patient turns their head while taking a deep breath, are designed to reproduce that compression and confirm if an upper body pulse disappears, helping us distinguish between atherosclerotic disease and a mechanical compression syndrome.
And the cold and warm test is specific to distinguishing PVD from Raynaud's phenomenon, which is a very different mechanism of arterial failure.
Very different. Raynaud's is a functional disorder. It's severe, inappropriate vasospasm, the vessels clamping down acutely in response to cold or stress. It is not a fixed blockage. The test involves exposing the digit to ice, which in Raynaud's causes an immediate dramatic change to white, followed by blue. Warm water exposure then causes a rapid compensatory red flush. This just helps us ensure we aren't confusing structural blockage with an extreme physiological spasm.
We're circling back to the nervous system. We noted earlier that sensation over an ischemic zone is often described as hyperesthetic, abnormally sensitive, rather than numb. Why this heightened sensitivity?
This hyperesthesia is a key indicator of acute active ischemic pain. The nerve endings are acutely deprived of oxygen, leading to irritation and an exaggerated response to stimuli. The patient will often recoil from even a light touch because the underlying nerve tissue is, well, screaming from hypoxia.
And this stage often precedes the total numbness.
It precedes the complete loss of sensation associated with chronic nerve death or neuropathy.
Which brings us back to the critical need to thoroughly evaluate peripheral neuropathy in diabetic patients.
You cannot separate diabetes from PVD. In diabetic patients, the neuropathy can completely mask the pain associated with a severe ischemic ulcer or even gangrene. The clinician has to rigorously check the peripheral nervous system, vibration sense, which is often the first to go, light touch, and position sense.
So severe PVD with no pain is a bad sign.
It's a terrifying combination as they lack the body's natural warning system, allowing infection and tissue damage to progress completely unnoticed.
And finally, a key infection check: the lymph nodes.
Lymph node examination is mandatory, especially if there is any sign of wet gangrene or a deep infected ulcer. We check the inguinal nodes, those in the groin. Enlarged, tender, or inflamed lymph nodes are concrete evidence that the body's lymphatic system is actively fighting a spreading bacterial invasion originating in the distal limb.
It confirms the infection is systemic.
It confirms the systemic nature of the infection and often necessitates rapid antibiotic and surgical management.
This procedural depth from pulse mapping down to the degree of sensitivity provides the data required to quantify the damage. Now let's move to the final stage: listening for evidence of flow disruption and synthesizing the overall clinical picture.
We've looked, we've felt, and we've timed. The last physical assessment technique is auscultation listening.
We're listening over the major arteries, like the femoral, for bruits. Can you describe the sound of a bruit and what it means in this context?
A bruit is a whooshing or buzzing sound, very similar to the sound water makes when it rushes through a pinched hose. It's caused by blood accelerating through a narrow or irregular segment of the artery, which creates turbulent flow.
So finding one is a clear sign of a problem.
Finding a prominent bruit over the femoral artery, for example, suggests significant stenosis, a narrowing of the vessel right at that point. We also listen over abdominal vessels, as aneurysms often produce a bruit as well.
You raised an important procedural caution: avoiding excess pressure with the stethoscope.
That's a critical technical point. Pressing too hard with the bell or diaphragm can mechanically compress an otherwise healthy artery, artificially creating turbulence and a false bruit. The listening has to be gentle enough to detect natural turbulence without inducing it.
Beyond auscultation, the reactive hyperemia test is essentially a short, sharp physiological stress test. What is the fundamental principle of what this test is measuring?
It measures the body's ability to pay back an oxygen debt. The goal is to see how rapidly the circulatory system can recover and compensate after a period of total deprivation.
How is it done?
We inflate a pneumatic cuff to about 250 millimil Hg, blocking all arterial flow, and we keep it inflated for 5 minutes.
5 minutes of total ischemia. That sounds uncomfortable, but necessary.
It is necessary, and 5 minutes is sufficient to create that oxygen debt. When the cuff is released, a healthy arterial system immediately responds with massive vasodilation. The vessels open wide to rush blood back in and clear the metabolic waste.
What's the normal response time, and how does a delay confirm arterial disease?
A normal result is a quick return of color, a hyperemic blush, in just 1 to 2 seconds. If that blush is significantly delayed, say 10 or 15 seconds, it confirms arterial disease. The arteries are either too stiff from calcification, too narrowed from plaques, or just too compromised to fully dilate and initiate that rapid influx of blood. It's a quantifiable, measurable sign of circulatory sluggishness.
We've built up a huge amount of data. Let's synthesize this into the core clinical observations, the signs that instantly indicate severe, critical, limb-threatening ischemia. What's the cheat sheet, so to speak?
If the clinician has to relay urgency, they focus on 5 key findings. First and foremost, that visual combination. Elevation pallor combined with dependent rubor. That is the unmistakable visual signature of advanced chronic ischemia.
Second,
the anatomical map. Absent pulses below a certain level precisely locates the obstruction and guides potential intervention sites.
what about the signs of infection and acute blockage?
Third, the emergency sign. Crepitus. If that crackling is felt, it means gas gangrene, and that patient needs an operating room now. Fourth, the signs of acute shutdown. Severe sudden pain combined with associated edema and pallor often screams acute ischemia from an embolus or thrombosis.
And the final distinction we covered on tissue viability.
The visual confirmation of contained versus spreading tissue death, the presence of a clear line of demarcation confirms dry, stable gangrene versus the indistinct, spreading nature of dangerous wet gangrene. These synthesized clues allow the clinician to classify the urgency and severity, often using standardized scales.
The physical exam is done. We have a severity classification and a location. Now, what are the definitive objective tools used to confirm the diagnosis and plan the surgical strategy?
We begin with the non-invasive tools, led by the Doppler and the ankle brachial index, or ABI. The ABI is an elegant yet simple metric. It's the ratio of the systolic blood pressure measured at the ankle, using a Doppler probe to hear the flow divided by the systolic blood pressure measured in the arm.
What does that ratio tell us about arterial efficiency?
It's a direct measure of arterial pressure efficiency. In a healthy person, the ankle pressure should be slightly higher than the arm pressure, yielding an ABI near 1.0 or 1.1. If the ankle pressure is significantly compromised due to stenosis, that ratio drops.
So a low number is bad.
Very bad. An ABI of 0.9 suggests mild disease. An ABI below zero point 0.4 often indicates severe critical limb ischemia. It's an objective number that quantifies the damage.
And the duplex scan.
The duplex scan is an ultrasound that combines traditional imaging with flow analysis. It's used to visually map the blood flow dynamics, pinpointing the exact location and degree of stenosis or occlusion identified clinically and suggested by the ABI. It shows us where the trouble is in real time.
For surgical planning, we move to high-resolution cross-sectional imaging, CTA and MRA.
Yes, computed tomography, angiography, and magnetic resonance angiography. These are essential for lesion planning. They use contrast dye and high-powered scanners to create detailed 3D reconstructions of the entire arterial tree. This allows the surgical team to map the inflow vessels, the location of the block, and the quality of the runoff vessels below the obstruction.
And that detail is critical for planning the surgery.
It is absolutely critical for planning a bypass surgery or an endovascular intervention.
We also look at ancillary tests, like a simple X-ray. Why include an X-ray when we have these sophisticated scanners?
X-rays serve two primary purposes. First, they look for extensive arterial calcification calcium buildup in the walls of the arteries, a sign of advanced hard atherosclerosis. This calcification can complicate procedures like stenting. Second, and crucially, X-rays are the fastest way to confirm the presence of gas in the soft tissues, objectively verifying the suspicion of gas gangrene raised by that clinical finding of crepitus.
However, when the patient is definitively heading for the operating room, when the plan is to physically reconstruct the plumbing, there is still one reigning gold standard investigation.
The gold standard for operational management remains arteriography. This is an invasive procedure where a catheter is inserted and contrast dye is injected directly into the arterial system. It provides the highest resolution, clearest roadmap of the vascular anatomy.
So all non-invasive tests are great for screening.
Surgeons often rely on arteriography immediately prior to or during the actual intervention because it provides the definitive, dynamic picture of flow.
All of this complex, life-saving decision-making rests on meticulous record-keeping. What are the non-negotiable standards that must be precisely documented in the patient's record?
Every single piece of quantifiable data gathered must be recorded. This includes the description of skin color, the level of temperature change, the neurological status, and the precise location and size of any ulcers or gangrene. The pulses must be graded consistently, usually using a 0 to 3 scale, where 0 is absent and 3 is bounding.
And the quantifiable metrics.
We must document the timing tests, the capillary refill time, the venous refill time, and that definitive severity marker, Berger's angle. Finally, the patient needs to be classified using an internationally recognized system, like the Rutherford classification or the WIFI classification system, which provides a more granular assessment of limb-threatening status.
It's impressive how the difference between standard and life-saving care comes down to this granular detail. You're not just noting pulse is weak, you're noting DP pulse 13, popliteal 03, Berger's angle 15 degrees.
That precision is the justification for immediate, aggressive surgical intervention. It ensures that the rest of the medical team and any subsequent surgeon immediately understands the gravity and the exact anatomical location of the circulatory failure.
This deep dive has shown us that the peripheral vascular disease examination is one of the most elegant and crucial protocols in medicine. We started by looking for signs of systemic failure, the heart problems, the risk factors, and ended by translating the language of gravity and color into precise angles and timing, like that 20-degree threshold of the Berger's angle.
I think our mission was a success. We've established how observation and palpation, when applied systematically, quickly locate the level of arterial occlusion and quantify its severity. The data derived from these bedside tests, especially the quantifiable timings and angles, are the essential guides that dictate the need for revascularization and the path to limb salvage.
It provides clarity in a chaotic situation. We know that arteriography is the ultimate gold standard for operational planning, the definitive image that guides the surgeon's hand.
And we've covered the entire sequence of clinical steps that lead up to that decision.
So, that leads us to our final provocative thought for you, the learner, to mull over. Since arteriography is the gold standard for operational planning, what single quantifiable clinical sign observed on examination is the strongest, earliest predictor that a patient will ultimately require that definitive, invasive imaging, even before the Doppler is wheeled into the room?
Consider which test confirms the most irreversible, profound failure of the circulatory pump to sustain flow against even minor physiological stress.
Thank you for joining us for this deep dive into the critical protocol of PVD assessment. Until next time, stay curious and keep learning.